Okay, so picture this. You're in the ER, a patient comes in, and their heart is just not beating right. It's like irregular. And you're thinking, is this AFib? How do I even know for sure what needs to happen right now? These are the questions we're going to tackle in this deep dive. We're going to go deep into the 2024 ESC guidelines for atrial fibrillation management. And we're going to focus on what you need to know in those really critical moments, especially when AFib leads to acute heart failure.
Yeah. It's all about having that crucial knowledge right there at your fingertips so you can just make the best decisions quickly and confidently for your patient.
Right, because in the ER, time is everything.
Yeah.
So let's start with the fundamentals, but we're not talking basic AFib 101 here. We're going to go a little deeper. Think back to your physiology classes, those electrical signals in the heart.
Right, you got it. Now imagine those signals in the atria, the top chambers of the heart. They're just going haywire. Instead of that coordinated squeeze, they're just quivering, fibrillating. And this just throws off the entire rhythm of the heart.
So it's not just an electrical problem. It really affects how the heart pumps.
Absolutely. So you see the atria. They usually act like primer pumps. They're topping off the ventricles before the ventricles send blood out to the body. But with AFib, that priming action is totally lost. The ventricles still contract, but they're not getting that extra boost. So blood flow becomes inefficient.
You got a patient, irregular heartbeat, you suspect AFib.
Yeah.
How do you confirm it?
The 12-lead ECG is really your go-to tool here. You're looking for those classic signs of atrial fibrillation. And what immediately jumps out at you is the lack of those distinct P waves, the ones that usually signal atria contracting. Instead, you'll see this chaotic baseline.
What about the ventricular rate?
They're regularly irregular, of course. The ventricles are responding to that chaotic electrical activity in the atria, so their rhythm is all over the place.
Okay, so ECG points to AFib. Are we done? What about blood work?
Never skip the blood work. It's not just about confirming the diagnosis. It's about getting the whole picture. You need to rule out other conditions that might mimic AFib and identify any underlying factors that could be contributing to it.
So what are we checking for specifically?
Think about what could be stressing the heart. Kidney function, electrolytes like potassium and magnesium, liver function, blood count glucose, and HbA1c to check for diabetes. And thyroid hormones. All of these can play a role in AFib.
All right, so you've got your diagnosis, AFib confirmed. Now what? What are the most immediate dangers that we need to consider in the ER?
Yeah, we're talking about two major threats here, heart failure and stroke. These are the big ones that keep us up at night.
Okay, let's start with heart failure. Why is that such a risk with AFib?
Remember how we talked about the atria not priming the ventricles effectively? Well, that inefficient pumping can overwork the heart and eventually lead to heart failure. In fact, almost half of all AFib patients will develop heart failure.
Wow, that's a sobering statistic. And the stroke risk, I know that's a huge concern with AFib.
It is a major concern, and here's why. When the atria are fibrillating, blood flow slows down, and that creates the perfect environment for clots to form. These clots can then travel to the brain, blocking blood vessels and causing a stroke.
So we've got this double whammy. The heart itself is struggling, and there's this looming threat of stroke. We got to act fast.
Absolutely. And that brings us to the critical decision point. Do we focus on controlling the heart rate, or do we try to restore normal rhythm?
Rate control versus rhythm control. That's a big decision. How do we choose?
Well, the latest ESC guidelines actually recommend a combination approach tailored to the individual patient. But in the ER, it often comes down to how stable the patient is and the severity of their symptoms.
So let's walk through a scenario. You've got a patient in the ER with AFib who's showing signs of acute heart failure. They're struggling to breathe. Their blood pressure is dropping. What do you do first?
In that situation, you need to act fast. We're talking about a hemodynamically unstable patient, and that's where the algorithm in Figure 7 of the ESC guidelines becomes your lifeline, specifically the branch for hemodynamic instability.
And what does that algorithm tell us to do? What's the top priority?
It's clear, electrical cardioversion. That's a Class I recommendation. The strongest possible in this scenario. It's the quickest way to restore normal rhythm and stabilize the patient.
So electrical cardioversion is our first line of defense. But what about managing that rapid heart rate?
Rate control is also crucial in this situation. The guidelines recommend medications like beta blockers, digoxin-diltiazem, or verapamil. They all work in slightly different ways, but the goal is the same. Slow down the heart rate and improve blood flow. to vital organs.
Okay, so we have two primary tools in our toolkit. electrical cardioversion
Mm-hmm.
to shock the heart back into rhythm,
Yeah.
and medications to slow things down.
Yeah.
But which one do we choose?
And when? Well, that's where you have to assess the situation carefully.
Okay, so let's break down the two main types of cardioversion, electrical and pharmacological. What are the factors that tip the scales in favor of one approach over the other?
When you're facing a patient in acute distress, someone who's hemodynamically unstable, recommendation table 16 of the guidelines is very clear. Electrical cardioversion is the gold standard.
Because it's the fastest way to restore normal rhythm.
Exactly. In those critical moments, you need to act quickly. Electrical cardioversion delivers that immediate impact.
But what about pharmacological cardioversion? When would that be the preferred approach?
Pharmacological cardioversion, using medications to kind of coax the heart back into rhythm, is a gentler approach. It's often a good option when the patient is stable and we're dealing with recent onset AFib.
So if someone comes in and their AFib just started a few hours ago, they're not in immediate danger. A pharmacological cardioversion might be a good first step.
Exactly. Recommendation table 17 lists flecainide, propafenone, and vernicillin as the go-to drugs. Each one has its own nuances and specific situations where it shines.
So much to consider when choosing the right medication.
It's about weighing the risks and benefits for each patient. But let's say you've successfully restored normal rhythm, whether through electrical or pharmacological cardioversion. You're feeling good, the patient is stable. Are we in the clear?
I have a feeling you're going to say not so fast.
You know me too well. We can't forget about the long game. Remember that stroke risk we talked about earlier? That doesn't just disappear because the rhythm is back to normal.
So even after cardioversion, we still need to be vigilant about preventing clots.
Absolutely. Recommendation Table 6 and Section 7.2.1 of the guidelines are crystal clear on this. Anticoagulation is essential to prevent stroke in AFib patients.
Okay, so how do we approach anticoagulation in this setting? Walk me through it.
First things first. In most cases, you need at least 3 weeks of anticoagulation before cardioversion. Think of it as prepping the battlefield, reducing the risk of dislodging a clot during the procedure.
That makes sense. But what if you need to perform cardioversion sooner, like in an emergency situation?
That's when you bring in the heavy artillery, a transesophageal echocardiogram, or TOE. It gives you a direct view of the heart, allowing you to rule out any existing clots before you proceed with cardioversion.
So it's like a safety check, making sure the coast is clear before you hit the go button on cardioversion. And what about after the procedure? How long does anticoagulation need to continue?
The guidelines recommend at least 4 weeks of anticoagulation after cardioversion, but remember, it's not a one-size-fits-all approach. Some patients might need longer-term anticoagulation based on their individual risk factors.
So we're always factoring in the patient's specific situation, their history, their risk factors, their overall health.
Absolutely. It's about personalized medicine, tailoring the treatment plan to each individual patient. And speaking of personalized medicine, there's something else I wanted to touch on. We've talked about the immediate dangers of AFib, but there's also this longer-term consequence that we can't ignore: atrial cardiomyopathy.
Atrial cardiomyopathy. That's not a term you hear every day. Sounds serious.
It is. It's essentially a remodeling of the heart's atria due to the strain of AFib. Imagine those atria working overtime, constantly quivering instead of contracting effectively. Over time, that takes a toll.
So it's like the atria are getting worn down, almost like a muscle that's been overworked. What are the implications of that?
Atrial cardiomyopathy can lead to fibrosis, enlargement of the atria, and ultimately a decline in the heart's ability to function properly.
So it's not just about managing the immediate crisis of AFib. We also need to be thinking about preventing or slowing down the progression of atrial cardiomyopathy.
Exactly, and that's where early diagnosis and aggressive management of AFib becomes so important. The sooner we can get that heart rhythm under control, the better the chances of protecting the heart in the long run.
So it's like a race against time. We need to stabilize the patient now, but we also need to be thinking about strategies to prevent future complications.
You got it. It's about seeing the big picture, the whole patient, not just the immediate problem.
Okay, I'm starting to see how complex AFib management can be. It's not just about following a set of rules. It's about understanding the nuances of the condition and making informed decisions based on each patient's unique situation. But there's one thing I'm still struggling with. In these guidelines, they keep mentioning Class I recommendations. What does that actually mean in practice?
Oh, that's a great question. It's not just medical jargon. A Class I recommendation means there's strong evidence supporting a particular treatment and that the benefits clearly outweigh the risks.
So when we see a Class I recommendation in the guideline, it's basically a green light saying, this is the best course of action in most cases.
Pretty much. Think of it as a guiding principle, not a rigid rule. There will always be exceptions, but a Class I recommendation is a strong indicator that you're on the right track.
Okay, that makes things a lot clearer.
Hmm.
And while we're on the topic of guidelines, one thing that really struck me in the 2024 ESC guidelines is this emphasis on personalized care. It seems like a real shift from the one-size-fits-all approach.
It's a welcome shift, for sure. For too long, we've treated AFib as a one-dimensional problem. But the reality is far more complex. Every patient is unique with their own set of risk factors, comorbidities, lifestyle, and preferences.
So it's not just about treating the AFib, it's about treating the whole person.
Exactly. Personalized care means taking all of those factors into account, their age, their overall health, their values and priorities, and tailoring the treatment plan to their individual needs.
That sounds like a lot to juggle in the fast-paced world of the ER. How do we even begin to approach personalized care in such a time-sensitive setting?
It starts with asking the right questions, really listening to the patient, understanding their concerns, their goals, their fears. It's about having an open and honest conversation, explaining the risks and benefits of different treatment options, and involving them in the decision-making process.
So it's a partnership, not a dictatorship.
Precisely. We're not just prescribing treatments, we're guiding patients through their healthcare journey. And that brings me to something that really stands out in these guidelines, something that's almost like a cheat sheet for urgent care physicians. Table 17.
Table 17, the one for pharmacological cardioversion. What's so special about it?
It's got this brilliant section called What to Do and What Not to Do. It's like distilled wisdom from the experts giving you those practical tips and red flags to look out for.
I remember seeing that. It's super helpful, especially for someone who's dealing with AFib in the ER on a regular basis. It cuts through the noise and gets right to the point.
And what's really interesting is that it emphasizes the importance of patient selection. For instance, it highlights certain conditions like severe left ventricular hypertrophy or recent acute coronary syndromes where pharmacological cardioversion might not be the best approach.
So it's a reminder to use our clinical judgment, not just blindly follow a protocol.
Exactly. The guidelines provide the framework, but we as physicians need to apply that knowledge to each individual patient.
Okay, so we've covered a lot of ground today, from the pathophysiology of AFib to the latest diagnostic tools from rate control versus rhythm control to the importance of anticoagulation and personalized care. But if there's one thing you want our listeners to take away from this deep dive, what would it be?
I would say this. AFib is a complex and ever-evolving condition. Our understanding of it is constantly growing, and the guidelines reflect that. So stay curious, stay informed, and stay up to date on the latest research.
Sounds like good advice for any medical professional, really. Never stop learning. But for those of us who are on the front lines dealing with AFib in the ER, what's the most practical piece of advice you can offer?
Don't be afraid to question assumptions. Challenge the status quo. And above all, remember that your patients are your partners in this journey. Listen to them, respect their wishes, and work together to find the best possible solutions.
Well said. So that wraps up our deep dive into atrial fibrillation for the urgent care physician.
It's been a pleasure sharing these insights with you.
The feeling is mutual. And to all of you listening out there, we hope you found this deep dive informative and empowering. Remember, knowledge is power. The more you know, the better equipped you'll be to make those crucial decisions that impact your patients' lives. So stay curious, stay engaged, and keep diving deep.